Hello. In this presentation, we're going to be looking at some of the common infectious disease disorders seen in adults. When we talk about infectious diseases, we need to talk about diseases that are emerging and re-emerging. And we do have newly discovered and previously unknown infections that threaten public health. Well, I don't need to say we've lived through a year and a half of COVID-19, which was not on the horizon 3 years ago. And part of the reemergence or emergence of these is due to increased travel. We are a much more mobile society, and it is much easier to transmit infectious diseases across continents, across the world. Whereas years ago, before airline travel, many years ago, you could more or less keep these infections confined to, the country of origin or the area of origin. Another is drug resistance. We have diseases, disorders that are resistant to some of the common therapies that we've had. MRSA is just a classic example of that for you. Environmental changes, things like deforestation. We are changing the world in such a way that it is pushing disease-carrying animals into the population. I think just thinking about something like the ticks that come off deers. I live in a pretty suburban little area, and the deer population in my backyard has gone through the roof. So that's just a simple example there. And then new pathogens that we've not dealt with before. And hence the COVID-19, and now we have the Delta variant. So just some examples of what's happening here with the emerging and re-emerging diseases. Some examples of some type, ARDS. We have the Middle East respiratory syndrome. We have the human metapneumovirus, influenza A, avian, the bird flu, influenza A from several years ago, acute diarrheal disease, vector-borne diseases, zoonosis, and then again our antibiotic resistance, which we mentioned. So clinical presentation, physical exam. There can be significant variances of presentations based on the etiology of the disease and the pathogenesis of the disease or pathogenesis. Typically, though, some common things we look for are things like fevers, rashes, cough, muscle aches, arthralgias, diarrhea, and neurologic changes. Good assessment always includes questions about travel. Have they been out of the country? Have they traveled to a different area? Exposure, need to keep in mind the public health data and clinical findings. A good example of public health data is, if we have certain states that are having a higher incidence of COVID-19 Delta variant infections, so it would be important to know if you have a patient, have they recently been to one of these states that is experiencing higher numbers? Certain states have more Lyme disease just because of the wooded nature of the state. Lyme disease first began, I believe, in the upper eastern part of the country, and pretty much now it's everywhere. But diagnostics based on clinical protocol per the clinical findings. Obviously, labs are done. You may use imagery, pathology studies, and we're going to talk about some of the differential diagnoses. And again, that varies based on the etiology and clinical symptoms that you're seeing. And management, we have condition-specific protocols for management. We're going to spend just a little bit of time talking about HIV infection. And this is a retrovirus, human immunodeficiency virus. We have HIV-1, HIV-2. HIV-1 was first transmitted from chimps to humans back in the early 20th century. HIV-2 is a genetically distinct retrovirus transmitted from monkeys to humans. HIV-2 is the one that causes AIDS. It is much less prevalent than HIV-1, both globally and in the United States. AIDS is acquired immune deficiency syndrome. Criteria for diagnosis of AIDS would be laboratory documentation of the existence of an HIV infection and one of the broad spectrum of opportunistic infections, the malignant neoplasms or nonspecific syndromes, or lab documentation of the infection and a CD4 cell count of less than 200 per millimeters cubed. No, yeah, to the third. And AIDS is actually a clinical case. So transmission, we know AIDS is transmitted sexually. It can also be transmitted parentally through either IV drug use, blood product transmissions, and can be transmitted from mom to child during pregnancy or breastfeeding. Clinical presentation varies significantly, and again, it's based on the staging of the infection and the CD4 count. They may look very healthy, very well, no overt illness, or an acute infection or neoplasm. Counseling is always mandated. And again, good assessment of their past medical history, their social sexual history, med substance abuse, any psych or alternative therapies that they've used, and a good physical exam with special emphasis on neurological assessment, skin assessment, heads, eyes, ears, nose and throat, liver, and genital assessment. Diagnostics is the ELISA or the Western blot. It is repeated in 3 months. We're looking at HIV polymerase chain reactions, or what they call PCR. There is that window period for testing, reflex testing for infection, and again, that CDC algorithm does recommend reflex testing with an HIV presentation. Extensive additional lab testing, CD4 count, syphilis, CMV, Hep B and C, because a lot of times there's coexisting along with TB and others. HIV, you may see these patients in the primary care setting. You're not going to be independently managing HIV infections. These people will work with infectious disease. But you may see them in primary care, treating them for, primary care disorders. Management, again, physician consultation with an HIV specialist. ED referral immediate if there's any suicidal ideation, if there's a really rapid acute presentation, in other words, they come in really, really short of breath, or just really, really ill. They certainly will be on a variety of pharmacotherapeutic agents. There is the HAART therapy for HIV management, and again, that's done with their specialist. And very important for health maintenance and health promotion for these individuals. You want them to stay as active. Exercise is important. Good diet is important. Just for general purposeful well-being and health promotion. Next up is influenza. This is an acute, highly infectious, airborne infection of the respiratory tract, influenza virus A or B. Usually this is self-limiting, occurs in outbreaks. We see this more in the winter months when people were cloistered inside. Infection rates are highest in children, and again, tends to occur in outbreaks. When patients present with influenza, there's actually been an incubation period of 1 to 2 days, but someone presenting with influenza, it's an abrupt onset of symptoms. Doesn't happen gradually. They can tell you exactly when they started to feel sick, and it's fever, chills, headache, malaise, they're tired, their joints ache, they have the myalgias, they have loss of appetite. Oftentimes you'll see these respiratory symptoms. They'll have a dry cough, there'll be nasal congestion. Typically it's clear discharge, and they'll be complaining of a sore throat. Physical exam. If it's an uncomplicated influenza, the symptoms may be mild, or they may have some but not all of these symptoms, but a flushed face, watery eyes, their skin hot, moist, run in a temperature. If you look in their nasal passages, you'll see red and inflamed nares, the mucosa in there. If you're assessing, or I should say when you're assessing lymph nodes, you'll find cervical lymphadenopathy and pretty much an unremarkable pulmonary exam. You know, the lungs don't sound bad. How do we diagnose influenza? Nasal swabs or washings. You can do sputum tests, throat swabs. The nasopharyngeal specimens are the preferred source. Ideally, you would like to get these samples collected within 12 to 36 hours of when they first felt sick. And the gold standard for diagnosis is a viral culture, or by reverse transcriptase polymerase chain reactions, which is RT-PCR assays. Clinical diagnosis in the setting of a confirmed influenza outbreak is very accurate. So in other words, if influenza is around, you can pretty much clinically diagnose it pretty accurately. Some of the differentials, keep in mind, upper respiratory infections will present with similar symptoms. Mycoplasma pneumoniae infections, bacterial pneumonia, and severe strep pharyngitis. These people might, somebody with a severe strep throat may actually appear looking like an influenza. Managing. Specialist referral if you have somebody that are considered high risk for complications. In other words, if you have a pregnant individual, kids that are under 2 years of age, patients over 65 years of age. Automatic quick emergency department referral if you've got the cyanosis, the dyspnea, any confusion, any cardiovascular risks, any pulmonary risks, some of your long-term COPDers, CHFers. Treatment is primarily symptomatic, rest, hydration, antipyretics to bring down the temp. Obviously, keep them confined, no working during an infection. If antivirals can be helpful, but you want them within 48 hours of the known exposure. And again, we encourage the influenza vaccine for prevention. The seasonal influenza vaccines. Next up is infectious diarrhea. With infectious diarrhea, it's because of an exposure to viruses, bacteria, parasites. Any of those can cause infectious diarrhea. It can be foodborne, waterborne. It can be passed person to person, fecal oral route. It can be an acute episode. It could be chronic. An acute infectious diarrhea may be categorized as non-inflammatory, inflammatory, or what they call penetrating. So you can get some different unique clinical presentations and scenarios. Complications of infectious diarrhea: dehydration, malnutrition, sepsis. There are some different types. You can have non-inflammatory diarrhea, which is just an acute gastroenteritis. You can have traveler's diarrhea. In other words, they've been somewhere where, the food, water contaminants. Inflammatory diarrhea and food poisoning. And in that case, you've got bacterial toxins causing your diarrhea. A thorough history, looking at their clinical presentations. So doing your old CART, lab findings. Again, it gives you the kind of approach you're looking for. The PQRST, again, is just like the old carts of your diarrheal events. Obtain your weight, temp, orthostatic vital signs, because with dehydration, you oftentimes will have orthostatic hypotension occurring. Check their mucous membranes, their skin turgor, looking for dehydration. Look at their JVD, jugular venous pulsation. Assess their mental status, skin color. Are there any rashes? Cervical lymph node analysis. Check the thyroid. Good GI, abdominal assessment, and possibly a pelvic exam. Some of the differentials, again, you want to try to determine, is it inflammatory, non-inflammatory, or some type of penetrating gastrointestinal illness. Non-inflammatory illness suggests gastroenteritis, norovirus, rotavirus, or traveler's diarrhea. And again, you differentiate that from a more inflammatory, or what they call the penetrating disease. Management. Rehydration is really important. You want to prevent dehydration. They may need some anti-nausea agents. Whether or not you're going to prescribe some anti-motility agents determines what the underlying cause is. Obviously, if you've got toxins, you want to remove them from the system. You know, you don't want to slow down so more of the toxin is absorbed. Antibiotics, and obviously hospitalization if you have somebody that's compromised. Next up is infectious mononucleosis. This is an acute, self-limiting, generally benign disease, typically seen in children and adults after infection with your Epstein-Barr virus, cytomegalovirus, and other infectious agents. In addition to the Epstein-Barr, all of the agents listed below can be a causative agent for infectious mononucleosis. What this refers to is what they call the triad: fever, pharyngitis, lymphadenopathy. And regardless of what the infectious agent, the causative agent is, you will see fever, pharyngitis, and lymphadenopathy if you have infectious mononucleosis. Sources of infection: exposure to those oropharyngeal secretions. Blood products can come from genital secretions and breast milk. With an acute, during an acute phase, you'll see fever, they'll have the pharyngitis, you'll see lymphadenopathy, tonsillitis in adolescents. In older adults, you'll see enlarged livers, hepatomegaly, and jaundice. Temperatures can be as high as 104 degrees and last as long as 2 weeks. Typically, the symptoms will peak in about 7 days after they've started and become less pronounced during the next 1 to 3 weeks. That fatigue, though, that accompanies this mono can actually persist for several months. Some things that can occur but are less common are things like upper airway compromise, abdominal pain, rash, hepatomegaly, jaundice, and eyelid edema, swelling of the eyelids. You would want to do a thorough head, eyes, ears, nose, and throat exam, neck, skin, and abdominal exam, again, looking for that hepatomegaly. Diagnoses: CBC should be done, heterophil antibody serology, viral capsid antigen, or your VCA, your immunoglobulin Gs, IgG, IgM, and throat cultures, and do liver enzymes because of the effect that can be occurring on the liver. Some of the differentials that you would want to consider: Group A, beta hemolytic strep, hepatitis A, toxoplasmosis, cytomegalovirus infections, viral pharyngitis, and acute HIV infections. Management, again, adequate hydration, your nonsteroidal anti-inflammatories, throat lozenges or sprays for the sore throat, gargling with 2% lidocaine to relieve some of that pharyngeal discomfort, bed rest, make sure they are not doing strenuous exercise, totally avoiding contact sports because of the hepatomegaly that can be occurring here. Serial ultrasound if you suspect splenomegaly, another reason to keep them away from sports. You don't want a ruptured spleen. And if you have a complicated presentation, these folks should go to the emergency room. Or you see any signs of splenomegaly, any bruising around the abdomen, those kinds of people get an immediate referral. Next, we're going to talk about our tick-borne diseases. Ticks are very highly effective vectors to transmit multiple pathogens. We have ticks that are brought to us by white-tailed deer and field mice. Some of the things that I mentioned previously when I talked about all the deer in my backyard, environmental changes, things like global warming and deforestation. And with deforestation, what's happening up here where I live, again, it's fairly rural. I said suburban, it's actually more rural, but homes are going in wooded areas where deers used to, roam freely. So they are coming into folks' backyards. The other day, honestly, we were pulling out and there were 3 deer standing in the front yard of one of our neighbors. Okay, commerce and trading, increasing human population because we are moving into places that deers used to be their habitats. Types and spread, the Loxodese tick species. We have things like Lyme disease, which we're going to spend a little bit of time with, babiosis, anaplasmosis, ehrlichiosis, and Rocky Mountain spotted fever. And these are the various agents, vectors that carry them. Lyme disease can be asymptomatic, or you can see acute symptoms, fever, headache, arthralgia. We're going to spend a little more time talking about Lyme disease. The babiosis can be asymptomatic. You can have mild to moderate viral-like illnesses, severe disease that can result in death or a persistent relapsing course. Signs and symptoms here would be intermittent fever, chills, sweats, headache, again, the myalgias, the arthralgias, anorexia, and cough. That anaplasmosis presents as a pretty nonspecific febrile illness. They'll have shaking, chills, myalgias, and a headache. For these, obviously, get your vital signs, thorough physical exam with a particular focus on neurologic presentation, so good neuro exam, musculoskeletal, cognitive, dermatologic, and cardiac assessment. With Lyme disease, a good history clinical scenario. You will see the arthralgias, that erythema migrans, a headache. Look for the clinical characteristics. Diagnosis is with the ELISA or the Western blot test. With Lyme disease, pretty much early on, 2 to 32 days after they've been bitten, after they've had the tick bite, they'll most likely have a fever, chills, headache, myalgias. They have that erythema migrans, a ring-like rash that spread outward, often with the central clearing. And this is this bullseye. Bullseye doesn't occur not even in 50% of the people. So although that's a classic symptom or sign, not a lot of people have it. Your book says 75% of cases. It's actually a little less than that. Okay, for presentation, closer to 50. With your cardiac involvement then, that typically happens 5 weeks to 7 months after the bite. They might present with chest pain, syncope, dyspnea. They can develop heart block, they can develop myocarditis, and then the neurological involvement, 5 to 7 weeks after the bite. They might have severe or prolonged headaches, stiff neck, nuchal rigidity, cranial nerve palsy, peripheral neuropathy. They might present with Bell's palsy. You should get a lumbar puncture again, because you're thinking of, with any meningeal symptoms that present, and that cerebrospinal fluid may show lymphocytic pleocytosis. With the babesiosis, anaplasmosis, ehrlichiosis, you can do Glemmer or right stain, blood smears, PCRs can be run. With Rocky Mountain spotted fever, you'll see a profuse or purpuric eruption in the skin, appearing first on ankles, wrists, and forehead, but rapidly spreading to all parts of the body. And Rocky Mountain spotted fever can be potentially fatal. So you really want to diagnose these as soon as you can, um, to get treatment started. Um, some of the differentials, things like erythema multiforme, herpes simplex type 1, varicella, with the arthritis, reactive arthritis, polyarticular juvenile rheumatoid arthritis in kids, previously untreated Lyme disease. Oftentimes, if somebody's had Lyme disease and didn't know it, they can have quite severe arthritic syndromes that occur, again, months to years later. Management, again, it varies by the stage of the disease. With Lyme disease, the anaplasmosis, ehrlichiosis, Rocky Mountain spotted fever, oral doxycycline, 100 milligrams twice a day for 14 to 21 days, actually. Second line treatment is amoxicillin, and we use that in kids younger than 8 years and pregnant women, or chloramphenicol. Third and fourth line treatments, cefoxitin, erythromycin, respectively. That babesiosis, atorvastatin plus azithromycin for 7 to 10 days, or alternatively, clindamycin and quinine can be used. Adjust the management. Again, each of these tick-borne illnesses have their own protocol, so you will be following the protocol at the time. Preventing Lyme disease is really important. So you want to stay, if you can't stay away from high tick prevalent areas, you want to wear DEET. You want your clothing tucked into your boots or your shoes. You don't want exposed ankles, shins and knees. And and you want to check for ticks after being out in a wooded area. And then you want to monitor patients that come to you with ticks that have been attached and or bites. Okay, next up is tuberculosis. TB is an airborne infection caused by the Mycobacterium tuberculosis. It's an acid-fast aerobic bacterium. 2 billion people have latent TB infection without signs and symptoms. Persons with active TB who don't get any treatment can infect an average of 10 to 15 people annually. So you see how quickly and effectively TB can spread. Concerns, we are seeing increased incidence of TB nationally and worldwide. It's primarily drug resistant. We do have multi-drug resistant TB. And we see this with the HIV epidemics, higher rates of poverty in our homeless population, in our population that's incarcerated, with drug use, increased number of immigrants living in crowded housing with poor health care, increased number of residents in long-term care facilities, and we don't have as much public health TB outreach as we used to. So the clinical presentation, anybody you suspect of having TB needs to be referred to pulmonary, needs to be referred to pulmonary. With latent TB, there will be no active symptoms. They'll have that positive antigen response. Pulmonary TB that's the most common tuberculosis site. They'll be tired with anorexia, weight loss, night sweats, cough, chest pain, may have blood in their sputum, irregular menstrual cycles, low-grade fever. You may have people that are asymptomatic with their initial presentation. Extrapulmonary TB, we see bone and joint involvement, genitourinary system, lymphatic system, and central nervous system. Physical exam, good review of symptoms. Physical exams are critical. You will hear commonly rales in the upper posterior portion of the chest. You'll see pleural effusions, lymphadenopathy, weight loss, and fever. So diagnostics, we can do a MAN2 test or interferon gamma release assays. You do an AP chest x-ray. You can do acid-fast bacillus sputum samples, and you obviously want to screen for susceptibility. Some of the differentials, it varies by the type of TB and the site of involvement. Pulmonary, again, being the most common. Things like pneumonia, acute bronchitis, a respiratory illness, and carcinoma would be things you would want to keep in mind for differentials. Management here, and again, there are always look to the current classification and symptoms and the current, because again, it is drug resistant. So as things change, you always want to make sure you're doing the most current treatments. First line drugs are things like INH, rifampin, rifbutum, rifampicin, pyrazinamide, and ethambutol. Second line drugs, you can see things like streptomycin, capricin, levofloxacin, maxifloxacin, gadafloxacin. The classification system for tuberculosis: class 0, no treatment; class 1, contacts a person with infectious TB, no treatment, but should be retested in 8 to 10 weeks. Children less than 5 years of age and immunocompromised adults should have a chest x-ray, be started on LTBI treatment. They should be retested after the last contact with the infected person. Class 2 have been infected with TB but don't have any evidence of clinically active disease. They would get INH, 5 milligrams per kilogram, maximum dose of 300, once a day for 9 months, long-term treatment for tuberculosis. If close contact of TB, infected persons with the TST treated with INH resistance TB, preventative therapy with rifampin, 10 milligrams per kilogram daily for 4 months should be considered there. Multi-drug treatment is required for anybody in class 3, 4, and 5. And again, diagnosis, this is one of the reportable diagnoses. Diagnosis of TB must be reported to the local health department. This is one of the reportable diseases. Some mosquito-borne illnesses, and again, typically mosquito birds bring this to us. They cause acute febrile illnesses, central nervous system infections, encephalitis, and aseptic meningitis. Typically, these are the leading cause of epidemic encephalitis in the United States, and we have malaria and we have the West Nile virus. Presentation. Most infections with the West Nile virus, SLE, are asymptomatic. Once you're past the incubation stage, then the person will present with an influenza-like illness, fever, arthralgias, myalgias, a maculopapular rash in half the cases, and you'll see it on the trunk. Malaise, headache, nausea, vomiting, diarrhea, generalized lymphadenopathy, enlarged spleen and liver. Malaria incubation is 1 month to 1 year. Physical exam, we're looking for rashes, arthritis, adenopathy, splenomegaly, photophobia, sensitive to light. Perform cognitive function, check their alertness, their speech, motor sensory function, um, cranial nerve exam, and you're looking for nuchal rigidity or stiff neck. Note the patient's geographical location and travel history. So, as with much of what we've talked about here, travel history is important. Have they been in any wooded environments, forest areas? All important questions. Diagnostics, you can do an enzyme-linked immunosorbent assay to detect IgM. Additional testing and imagery as needed, depending on what presenting signs and symptoms you see or what your exam shows. Some of the mosquito-borne differentials, and you can see it here. I'm not going to read them all through, but things like Lyme disease, leptospirosis, listeria, cat scratch disease, your rickettsias, vasculitis. Drug reactions is one to keep in mind with any of these rashes that present. Have they started on any new medications? Mosquito-borne management treatment is supportive. There are no real specific antiviral meds. Hospitalization for lumbar puncture to determine if we've got bacterial meningitis and some other causes. Methicillin-resistant Staph aureus or MRSA skin infections. Morbidity is significant. Pre-antibiotic area, these accounted for about 80% of bloodstream infections. MRSA does have a 30% mortality with antibiotics, high average of about 65%. CDC, just you don't need to know these, but the numbers of hospitalizations, bloodstream infections coming from methicillin, Staph aureus, and pneumonia. MRSA accounts for about 19,000 deaths a year, more than HIV, viral hepatitis, TB, or influenza. MRSA skin infections, this is just the evolution of drug-resistant Staph aureus. This is just kind of interesting as to what has happened. And again, Staph aureus, back in the 1940s, we had penicillin. Then we developed penicillin-resistant Staph aureus. Then we went methicillin, and through, in the late 1950s, I guess. Then the development of methicillin-resistant Staph aureus occurred in the 60s and the 70s, and you can see 2006 vancomycin tolerance, 1990s vancomycin immediate resistant Staph aureus, 2002 vancomycin resistant Staph aureus. So you can see, and this is just, you don't need to memorize this, but this is just giving you an idea of how resistance to our antibiotics develops over time. This is just a presentation of MRSA of the skin, differentiating with a streptococcal infection of the skin. Cellulitis with MRSA. This is an outpatient scenario, non-animal bite. You might see it from infantago, from some secondary skin lesions, things like eczema, ulcers, lacerations that then become a cellulitis. Mupircin 2%. If you have cutaneous abscesses or boils, incision and drainage, add the antibiotic. If you've got some numerous sites, rapid progression, and you can see the antibiotic choices there for you cutaneous abscesses or boils, and obviously extra caution in folks with impaired circulation and diabetes. Beta hemolytic strep is seen less frequently, and you can see things like clindamycin and Bactrim, doxy, and beta-lactam or linzoid alone. And good hygiene is extremely important, keeping the area clean and dry. This is just some table identifying some of the oral agents and adult dosages for community-acquired MRSA infections. That completes our presentation on infectious diseases, some common infectious diseases in the adults.